afternoon. I'd like to welcome you to today's Medical Center Hour. This is a program entitled Disclosing Medical Errors to Patients, Recent Developments, Future Directions. I'm Marcia Day Childress from the Center for Biomedical Ethics and Humanities, and I'm delighted to welcome you all here this afternoon. Today's program is the School of Medicine's Richardson Memorial Lecture, a lecture which occurs annually to remind and encourage our medical and nursing students, house staff, and seasoned practitioners to be reflective about their work and to attend carefully and compassionately to the persons who are their patients, and to think about and address the problem of medical error. Made possible by the family of the late Jessie Stewart Richardson, this lecture had its origins in a tragic, untoward incident in the hospital care of Mrs. Richardson. Remembering Mrs. Richardson's many decades as a teacher, her family chose to invest a portion of her estate in health professional education and patient safety. They are thus helping the School of Medicine and the Medical Center to foster clinicians' interest in patients as persons, to underscore health professionals' commitment to care that has the patient at its heart, and to explore without fear the medical mistakes that do happen and how we might better respond to and remedy harmful errors in practice. The Richardson Lectures have brought many distinguished speakers to Charlottesville, among them physicians, physician ethicists, a medical sociologist, physician writers, a poet, even a patient's spouse. We welcome today Dr. Don Richardson, Mrs. Richardson's son, and a local physician who is also a proud alumnus of the University of Virginia School of Medicine. Welcome, Don. Research shows a disclosure gap between patients' desire to be told of medical errors and health professionals' current practice of informing patients about mistakes. With less than half of all harmful errors that occur being disclosed to patients, surveys suggest that by not doing so, doctors and health systems risk losing patient trust and inviting malpractice claims. While the recent push for more transparent communication about harmful medical mistakes may have begun outside medicine, physicians now generally welcome and support this concept. A cascade of questions arises, though, around exactly how doctors should do this, what's to be disclosed, and at what level of detail, and with what with or without causal explanation. And when do you disclose? And how? Who does it? And to whom? With what sorts of words? And with or without apology? These developments herald nothing less than a momentous cultural change over the last decade in how the medical profession communicates with patients about harmful medical error, with obviously enormous positive implications for patient-physician relations and for patient safety. This Medical Center Hour, our annual program on medical mistakes and patient safety, inquires into the practical realities of disclosing mistakes and does so from the perspectives of both medicine and nursing, with Dr. Thomas Gallagher of the University of Washington and UVA critical care nurse Mary Hardy. Dr. Gallagher is the Associate Professor of Internal Medicine and Medical History and Ethics at the University of Washington in Seattle. He's published widely on the matter of medical error disclosure, including the crucial questions of how actually to do this. Mary Hardy is a Clinician III in our Medical Intensive Care Unit. While she was a graduate student and then working at the University of Washington, she and Dr. Gallagher worked together, and Mary is a co-author on some publications with Tom. You'll find brief biographical sketches of both speakers in your handout. We thank today not only the Richardson family for their generous support, but also the UVA Health Systems Committee on Patient Safety and the Office of Risk Management, especially Dr. Peggy Kluzogan and Mr. Abraham Segrist, for their many contributions to institutional improvement and culture change. Tom Gallagher.
Well, thank you. It really is a pleasure and an honor to be here today for the Richardson Lecture. I've heard a number of times from folks around the medical center how influential your support, Dr. Richardson, has been in terms of moving the culture of safety forward here. So I really thank you, and I know the folks in the medical center appreciate all that you've done in that area. We are experiencing, I think, an important transformation in the way we think about communicating with patients when things have gone wrong in their care. All of us aspire to be open and honest, but there's a gap between those principles, those expectations, and what's currently happening. We're going to talk very quickly about why there's that gap and some important and exciting developments to try to move forward in this area. We're seeing interest in disclosure accelerating in a number of domains. We're seeing growing experimentation to different approaches with disclosure, both at the level of healthcare organizations and, interestingly, at the level of malpractice insurers. One real challenge in this area has been the absence of standards. The previous standard was the Joint Commission standard, which just basically said you need to tell patients about all outcomes of care, including unanticipated outcomes, but didn't provide any guidance about how to do that. This is changing. The National Quality Forum Safe Practice on Disclosure is really a nice example for institutions about how to create an institutional support system around disclosure. A variety of states, including Virginia, have adopted laws trying to promote disclosure and apology. And this really fits with an increasing emphasis in healthcare on the importance of transparency generally. Both open communication among healthcare workers, but importantly, with patients. I don't know if we have any radiologists with us in the audience. I'll help you with this film. This was a patient who came to the University of Washington Medical Center for routine abdominal surgery. This is not a normal film. No one recognized that anything was amiss until they couldn't make it through the metal detector at SeaTac Airport. And this is when this 12-inch by 2-inch retractor was discovered in the patient's abdomen. Now, I didn't get this slide from the radiology teaching files. Some of you may recall having seen this on the front page of the New York Times. So you can imagine if you were a patient and saw a picture like this, how anxious it would make you feel about the safety of healthcare. I was curious to see this issue had also made it to the cover of Reader's Digest, although truth be told, I did want to know first, why is it that sex only gets better? I was still a little bit distracted and wanted to know, who are those daredevil stunt sisters? But I collected myself. We got back to the main article here, fatal hospital mistakes and how to avoid them. Turns out this was an article about nosocomial wound infections, many of which are not preventable, but again dramatizes how this has hit the public's consciousness. Although Richard Gere seems surprisingly unmoved by all of this, he's apparently on his serene path to happiness. So, even though I think there's this growing interest in disclosure, people are realizing that there's a gap between these expectations and what's currently happening. We know that the majority of harmful errors aren't disclosed, and when that disclosure does take place, typically it falls short of meeting patients' expectations in this area. One real challenge has been that there's relatively little prospective evidence about what specific disclosure strategies are effective. This really makes it hard for healthcare workers who are committed to being transparent to know specifically, well, what should I do? And in a few minutes, we're going to be watching a few examples for you to sort of think about strategies that work well and strategies that might not work so well. And in particular, the impact of disclosure on outcomes. Outcomes like patient trust and satisfaction, the likelihood of litigation. The literature in this area is also still developing, and it's making it hard for healthcare workers to know what to do. Some of them are adopting somewhat unorthodox approaches to disclosure. So here is the doctor who comes out of the operating room with his guitar, and he sings, "Listen up, my fine people, and I'll sing you a song about a brave neurosurgeon who done something wrong." This is one approach that you could take. From what I've heard and seen over the last day and a half that I've been here, UVA is making important strides towards developing more productive approaches than the singing surgeon to communicating with patients when there have been these problems. And very quickly, what I'd like to do is sort of move from the bedside all the way up through the level of health policy as it applies to disclosure. We'll talk about this as an individual doctor-patient conversation. We'll talk about the interprofessional issues around disclosure. We'll talk a little bit about institutional issues, health policies, a few reports from the field, and then we'll talk a little bit, if we have time, about some future developments in this area. Well, one area I want to make sure we're all on the same page about is definitions, and it's important to differentiate between medical error and adverse event. So medical errors here in the orange circle defined as the failure of a planned action to be completed as intended or the use of a wrong plan to achieve an aim. It's a mouthful. That's the IOM definition. If you look very carefully, it turns out that medical errors are very common. Fortunately, the vast majority of them are not associated with an adverse event. An adverse event is just defined as any harm that results from the process of health care rather than from the patient's underlying disease. So anytime we harm the patient through the health care we deliver, it's an adverse event. The vast majority of adverse events, though, are not associated with a medical error. Just because there was harm as part of health care doesn't mean that something went wrong, that there was an error. When I use the term disclosure of errors, I'm specifically referring to this area of overlap, where there's been an error happen that caused harm. The other way to think about this is that these are the subset of adverse events that are preventable, that are due to medical error. Now, of course, we need to be open and honest with patients when there are adverse events that were not due to error, but those in many respects are much more straightforward conversations. They're conversations we're used to having with patients, talking with them about complications in their care. Where the ante really gets upped is when we may have been responsible in some way for that bad outcome happening. But it's a common misconception that healthcare workers have. They consider all of this to be sort of something bad happened, something went wrong, and don't distinguish between the concepts of error and adverse event and think that through as it applies to disclosure. From an ethics perspective, there are really two rationale for disclosure. Some people frame disclosure as a type of informed consent. It's sharing the information with the patient that they need to make good clinical decisions. From that perspective, it's important to remember this is what some people call a positive obligation, an obligation that we have to come forward with information about errors, rather than waiting for the patient to drag it out of us with lots of questions. On the practical side, this is one of the real difficult challenges associated with disclosure, figuring out how much are we going to say up front, how much are we going to wait for the patient to ask questions. But other people have said, look, this is really not about informed decision-making at all. This is fundamentally about truth-telling. We have a professional obligation to be truthful with patients. It doesn't matter whether the information impacts their decision-making. We should share it with them anyways. This is an area where I would say that patients and providers sometimes are on different pages. Providers really think about disclosure as informed consent. But patients really think about this as a sign of respect for them as a person and think about the truth-telling dimensions. They focus less on how am I going to use this information to make decisions. Why are healthcare workers focused on this as a type of informed consent? I think in part it may be because if disclosure is really about consent, then maybe we don't have to disclose if, in quotes, the information wouldn't matter. The patient isn't going to do anything different. As you're going to see in a few minutes, some of the real dilemmas in this area come down to, do we need to share information with patients when it doesn't affect their care or their subsequent decisions? There are emerging regulatory requirements. I mentioned the Joint Commission at the state level as well. But every study that has looked at this has suggested there is a gap between these expectations and what's currently happening. So, for example, Bob Blendon did a survey where they asked a large group of patients and of physicians, healthcare workers like yourselves, had they experienced a harmful error in their own personal health care? For those who said they had, they asked, did the involved healthcare worker disclose the error to you and apologize? And only roughly a third of the healthcare workers in the sample who said they had experienced a harmful error in their own personal health care said the error had been disclosed to them. And other studies that have used similar questions in other venues, actually in other countries, have found roughly a similar proportion of patients experienced patients who you think would know if there had been an error who say it hasn't been disclosed. There are sort of two competing explanations for why there's this gap. One is that we know that disclosure is, in quotes, the right thing to do, but somehow we lack the moral courage to pull it off. I would favor a competing explanation, and namely that there are complexities in this area of disclosure that have not been fully explored. And it's those complexities that's making it difficult for healthcare workers to know, how do I turn this general commitment to transparency into practice? So for example, I hear all the time, so should I disclose minor errors? Or what if an error causes significant harm but it got better quickly? What about fatal errors? Do we need to tell family members about those? You would think on the one hand it's obvious. Of course you would tell them. But oftentimes when institutions are faced with this, they really worry that the benefits of disclosure are outweighed by the distress that they would cause to the family when nothing can be done at this point to remedy the situation. What about harmful errors in patients who are hopelessly ill? Patient with widely metastatic cancer, life expectancy of hours to days, a bad error happens. What are we trying to accomplish by sharing that information with the patient or their family? These are real examples where this focusing on disclosure as informed decision-making versus truth-telling can sometimes lead to different conclusions, and it's an area that healthcare workers and institutions really struggle with, trying to figure out, well, what's the appropriate thing to do? What about other healthcare workers' errors? I'm sure patients roll into UVA all the time. You're looking at their care and you're like, oh my gosh. You know, what happened? Do I need to say something to the patient about this? So this is just some of the areas where I think we need careful thinking, both from an ethics perspective and a practical perspective, about what are the salient issues here and how do we move forward. I think it would do a lot to close this gap. Well, a little bit about how patients and doctors think about disclosure. We know that patients conceive of error very broadly. We also know that patients, almost to a person, say if there's been a harmful error, even if the harm is minor, I expect that you'll disclose this to me. But in our research, patients told us of their concern that healthcare workers might hide errors. Not because they think we're evil. They just think, of course, it's human nature. If someone were involved in an error, why wouldn't they want to keep that to themselves? Physicians think about errors much more narrowly than do patients, and they agree with disclosure in principle. This is very, very important because some institutions are trying to enhance disclosure through what I would call moral exhortation. It's by reminding people that this is a duty that they have, that they need to live up to. And in my opinion, that's not effective because healthcare workers get that. They understand that this is an obligation that they have. They have trouble figuring out, so how do I turn that principle into practice? They want to be truthful, but they experience a variety of barriers to disclosure. And so to explore these barriers further, we've done a series of surveys of a large number of physicians in the U.S. and a large number of Canadian physicians, as well as some trainees both at Washington University and at UW, to sort of explore how would physicians approach disclosure. After beating people mercilessly about the head and neck, we got 63% of them to send their surveys back. And if you've gotten 63% of your physicians to do anything, you'll recognize that this is a pretty good response rate. So just very quickly, let me tell you about a few of these cases. In the focus group work we had done, one of the things that came out about factors that would influence disclosure was physicians said, well, it depends on how obvious the error would be to the patient. And by that they meant, well, if it's something that's obvious to the patient, I sort of have to say something. But if it's an error that the patient wouldn't be aware of unless I pointed out to them, they weren't so sure what they would say. We wanted to test that hypothesis. We also got a sense that there was a cultural difference across the specialties, that surgeons might be approaching disclosure slightly differently than internal medicine physicians. And so there were a couple of cases. Each doctor got one case. Half of the internal medicine doctors got an insulin overdose, so we'll talk more about it in a minute. This was an error that we thought would be obvious to the patient. The other half of the internal medicine doctors got a case where a patient has a VTAC arrest because they've become hyperkalemic and a doctor forgot to check the record. For comparison, the obvious surgical error was a retained surgical sponge. So we asked a variety of questions. One was, how likely would you be to disclose this error? 65% of the internal medicine doctors for insulin said, I would definitely disclose this case. Although a third were like, oh, probably. You cut that number in half for the hyperkalemia case. Remember, doctors were only getting one, so they weren't comparing one to the other. Surgeons were very enthusiastic about disclosure. 96% definitely disclosed this surgical error. It's a little different matter when you ask them what they would say. So we ask about whether or not they would include the word error. 71% would for the insulin case, 40% for the potassium case, again cut roughly in half. 14% of the surgeons in the US and Canada would include the word error when talking with the patient about a retained sponge. When you ask them about an apology, 9% of the surgeons in the case of the retained sponge would offer an apology. We don't know which of these approaches is correct. But there does appear to be a difference across the specialties in how they're approaching this issue. What else did we learn from the survey? About 65% of the physicians, when we asked them, does your hospital have an error reporting system? They said, I don't know. All of the hospitals did at the time. 64% were completely unaware of it. 19% felt like they got adequate information back from the hospital about errors that were taking place. Only 10% felt that the hospital adequately supported them and their emotional distress after errors. So from the survey, we concluded that there's support for the concept of disclosure, but there's little agreement about the content. What should we say? That less information would be disclosed for errors that aren't apparent, that the specialties appear to be approaching this differently, that there's unmet need for emotional support, and that disclosure training, therefore, could be very helpful. So let's actually think some more about how to do disclosure. It's very difficult to choose what words you would say when figuring out what you're going to tell a patient about what happened. And here's a case for us to consider. So you've admitted a patient to the hospital, diabetic patient to the hospital for a COPD exacerbation. You handwrite an order for the patient to receive 10 U of insulin. The U in your order looks like a 0. The following morning, the patient's given 100 units, 10 times their normal dose, later found unresponsive with a blood sugar of 35. Patient is resuscitated, transferred to the ICU. You expect the patient to make a full recovery. So this is a brief video clip that shows the doctor who wrote the order coming back later to talk with the patient about what happened. As you're watching this clip, think about what you think the doctor does effectively and what you think the doctor should have done differently.
Good afternoon, Mr. Thompson. I came by to see how you're feeling today.
I'm certainly feeling better than I did this morning. I blacked out, and they had to rush me to the intensive care unit. Things seem to have pretty much calmed down for me now. I had no idea I was so sick.
Actually, I wanted to talk with you more about what happened this morning and why you had to go to the intensive care unit. Now, as you know, patients with diabetes can have wide swings in their blood sugar. This morning, your blood sugar dropped all the way down to 35, which was dangerously low. This is why you passed out. Now, fortunately, we were able to get your blood sugar back up to a normal range, so I anticipate things to go smoothly from here on out.
That's sort of odd. My blood sugar has never been that low before. What do you think caused my blood sugar to be so low?
I'm almost positive it was a bad reaction to the insulin you got this morning. Now, we have adjusted your dose somewhat, so this probably won't be a problem in the future.
Bad reaction? What do you mean a bad reaction?
Looking back at your chart, it appears that you got more insulin than you needed. Now, we have a better sense of how much insulin you require, so this isn't likely to happen again.
I have been on the same dose of insulin for the last 4 years. Exactly how much insulin did I get this morning?
It appears the nurse gave you 100 units of insulin rather than the 10 units you normally take. Apparently there was some kind of miscommunication about what your normal dose was.
What? 100 units? You've got to be kidding me! What kind of a moron would give a patient who usually gets 10 units of insulin 100 units? Well, that could have killed me!
I understand why you're angry, Mr. Thompson, but there's no need to yell.
You'd be yelling too if someone almost killed you. You people have any idea what you're doing here?
The good news is the episode that happened this morning didn't cause you any permanent harm. Now, occasionally things like this do happen in the hospital, much as we try to avoid them and prevent them, but what I would really like for us to do, Mr. Thompson, is work together and focus on moving forward and getting your emphysema under better control so that you can go home from the hospital.
I want out now. I don't want to spend another minute in this hospital. No wonder no one would tell me why I had to go to the intensive care unit.
Well, you're going to have to be in suspense about whether or not this doctor is able to persuade the patient to stay. These are very difficult conversations to have. And they require, like any other skill, practice and training. And when we do training on disclosure, we give people vignettes like this to think about and actually ask them to practice. If we have time later on during our discussion, I'd be curious to know what you thought this doctor did well and what you might have encouraged this doctor to do a little bit differently. So as we're looking about institutional issues in disclosure, several of them are coming to the front. I think people are increasingly recognizing that disclosure is an institutional responsibility. That doesn't mean the attending physician is not important, but it means that ultimately it's the institution's responsibility to develop a system to support and promote disclosure. And that brings up questions about, well, what's the best model? Do we do train the trainer? Do we train disclosure coaches? Do we leave this up to the individual physician? We're seeing a recognition that disclosure is a team sport. Disclosure is not the individual doctor talks with the patient. We make errors as teams. We should think about communicating errors as teams. But that brings up very challenging issues around interprofessional collaboration and how do we integrate trainees into this process. And we'll talk very briefly about a couple of places that are really moving to integrate disclosure with compensation. They see disclosure as not the end of the story and have a formal program that tries to tie both of these together. So as I mentioned, disclosure has really been conceptualized as a doctor-patient conversation, but we do make errors as teams. Disclosure of them as a team, though, is complicated by the power dynamics that exist, particularly between the physician and non-physician members of the team. So together with Mary, we did a research study that looked at nurses' attitudes on disclosure. And Mary may share a little bit about some of that later with you, but found that nurses wanted to participate in the disclosure process, but really feel oftentimes left out and aren't sure what their role ought to be. But when you think about this as a team undertaking, there are really a couple of stages. Teams need to talk about the event, they need to plan the disclosure, and they need to actually carry out the disclosure. This can be more complicated than you would think. And I'd like to quickly show you two other video clips about a second case. This is a patient who's admitted to the ICU with seizures of unclear etiology. They're loaded with Dilantin 3 times a day, then switched over to Dilantin once daily, but the physician writing the transfer orders to the floor mistakenly writes for Dilantin 3 times a day rather than once a day. It's not noticed by the nurse or the pharmacy. Patient falls and hits their head. Is Dilantin toxic? And that's why they fell. Their head CT is normal, and the patient is worried that another seizure caused their fall. I just want to watch two clips quickly. Disclosure is a great way to promote a culture of collaboration and patient safety. This is this healthcare team talking with each other about what happened. Pretend that you were a coach watching this interaction and needed to offer feedback to this team about what they were doing well and what they might do differently.
How could that be? She's only on 300 milligrams daily. That's a pretty low dose.
That's not what you wrote. The order is for 300 milligrams 3 times a day. That's what she's been getting.
I checked the medication records, and she's been on that dose since she was transferred from the unit.
That's not what she was on in the unit. How did this happen? This must have gotten messed up somewhere. Doesn't the pharmacy reconcile these? Don't you guys? Why didn't this get picked up? She was on 300 daily in the ICU.
The TID dose is what you ordered. Look, here.
So this team is struggling a little bit to collaborate effectively around the conversation about what happened. Let's watch as they sort of talk a little bit about what they think they ought to say to the patient.
This is one of those situations where too much information might harm her, not help her. What I've seen work pretty well is to keep things very general, in this case focusing on this as a side effect of Dilantin. I don't think we need to tell her she got too much. Focusing on the positive usually helps. If we go into all the nitty-gritty about how this happened, I think we're asking for problems.
This really could have been terrible.
I'm okay with not making a big deal out of this, but I would like you to talk to her since she's asking questions.
So the team's struggling a little bit also in terms of disclosure planning, although interestingly at least the doctor and the nurse seem to be on the same page. We're calling this team, they're travelers on the path of least resistance. They're sort of colluding to share relatively limited information with the patient. You have to think as an institution, are we prepared to help this healthcare team think in a more collaborative way about what happened, do more effective disclosure planning, and then actually carry out the disclosure more effectively to the patient? We don't have time to watch this clip. You can imagine the healthcare team struggles a little bit when they're actually talking with the patient about what happened. But thinking about disclosure as a team activity is important. So let's step out to the next level, which is institutional issues associated with disclosure. The NQF Safe Practice provides a very useful roadmap for institutions that are interested in developing their disclosure programs. The NQF Safe Practices is a list of 30 consensus-based standards. Disclosure was one of 2 new safe practices last year. And they're interesting because they're linked to pay-for-performance and public reporting. And so hospital-specific compliance with these safe practices for hospitals that participate in the Leapfrog program are available to patients on the web. So if you went to the website and looked up University of Washington Medical Center, you can see different scores for each of these specific activities. So for example, we've got a quarter circle for CPOE. As Mary can attest, it's a little bit perplexing. Apparently you get a quarter circle if you wish you had CPOE, because that's as close as we've gotten. But nonetheless, we've got a quarter circle. But if you go over here to the safe practice score, drill down on that circle there, you actually see a score for all of the 30 safe practices. You can see down here, patient notified of problem in care delivery. The bar goes out to here. UW Medical Center got roughly a quarter of those available points. Now, are patients looking at the web and comparing hospitals at this degree of granularity? We don't know. But I think this is a powerful stimulus for organizations to try to move their disclosure programs forward. The safe practice emphasizes transparency as a core organizational value. Very importantly, it links disclosure with performance improvement. For too long, people have thought about disclosure as a service recovery and risk management issue, but it really is an integral part of the way we think about quality at an institution. It articulates a process of disclosure and details what a support system ought to look like at an institutional level. That includes some education, it includes some just-in-time coaching. So people ought to be able, a healthcare worker at 3 in the morning on Christmas ought to be able to call a knowledgeable disclosure coach who at the moment can help them get ready to talk with a patient about something that went wrong and some emotional support. So very quickly, what do we know about the impact of disclosure on outcomes? I just want to share with you quickly 2 reports from the field, one from the University of Michigan and one from Copic. So University of Michigan has a full disclosure program you may have read some about, and it links disclosure with an early offer of compensation. They have very positive reports of their experience. In the 5 years, their litigation costs have gone from $3 to $1 million, and the average time to resolution and number of claims have been cut down dramatically. trying to really make an early attempt to both tell the patient what happened and provide reasonable financial settlement very quickly. COPIC is another example. COPIC is a large Colorado malpractice insurer that insures mostly private physicians. They developed what they call their 3 R's program. The 3 R's program is basically a disclosure and early offer program, although it's different from Michigan's because it's a no-fault program. They don't scrutinize the quality of care. There's been an unanticipated outcome. Patient is potentially eligible for this program. There are important exclusions in the COPIC program that do not apply at Michigan. So if you have a patient death, attorney involvement, complaint to the Board of Medical Examiners, they're excluded from this 3 R's program, although they can obviously file a claim through the normal claims mechanism. And because patients are not asked to sign a waiver, another important difference with the Michigan program, COPIC does not ask the patient to waive their right to sue, and because these payments are not made in response to a written demand, the payments are not reportable to the National Practitioner Data Bank, which is a critical aspect of engaging physicians in this process. So the 3 R's process, the event gets reported. Most places are finding that early event reporting is the key to making processes like this work. The physician and COPIC need to be in agreement about whether this is a good idea. The doctor engages in disclosure, tells the patient about the program, and the 3 R's administrator reimburses the patient for their out-of-pocket expenses and lost time up to $30,000. So it's not a trivial limit. And this slide has a lot on it, but in the 5 years, COPIC has dealt with 4,000 events, 2,000 met the criteria, 500 or 1,600 of them were closed with no payment, meaning that COPIC interprets this as disclosure enough was sufficient, that when they asked the patient, do you have financial needs, they said, no, I'm good. 500 were closed with payment. The average payment per incident was only $5,600. COPIC's experience has been that if you offer compensation at a low level for some of these events, patients do not try to max out the system. It was typically help with things like child care, missing a mortgage payment, relatively modest expenses. And none of these cases, none of these 4,000 cases has proceeded to a full jury trial. So with this subset of events, COPIC has had good luck at trying to resolve them. But I think it brings up an important question about what is the role of compensation in this whole process. This cartoon is labeled A Time to Worry. The doctors are coming out of surgery and tell the patient, first, the good news, we're not going to charge you anything. Where does compensation fit into the puzzle? I think it's a very important open question. So lastly, I just want to mention a little bit on the health policy side and then turn things over to Mary. So 35 states now have adopted apology laws of some sort. The critical thing to know about these is that the protection that they offer varies. These laws are intended to encourage people to say that they're sorry by protecting portions of that disclosure or apology from being used in litigation. The protection is much more limited than you would think. 25 states, Virginia included, only protect an expression of regret. Meaning if you admit liability elsewhere in the disclosure statement, that's still admissible. So it protects the I'm sorry, but it does not protect the about what happened, that we harmed you for this error. Some states protect a little bit more, protect the entire disclosure statement, but as I'll mention in a minute, even that may be less protection than you would think. 8 states, and Virginia is not among them, but I think states are moving in this direction, mandate the disclosure of serious adverse events to patients. 2 of them, in fact, mandate the disclosure be done in writing, Pennsylvania and Oregon. And the disclosure burden, again, falls to the institution, not to the practitioner. But there are some real limitations of these laws. Even the broadest apology laws provide pretty limited protection. And the important thing for healthcare workers to understand is that disclosure can still trigger litigation. It just means that the words that you say during the disclosure can't be used as evidence of liability. But the patient can use any other independent means they want to prove that you were negligent. The laws are difficult to interpret, which I think is likely to compound inertia in this area. They don't view disclosure and apology as some sort of an integrated process, which, as all of you know, it really is one part and parcel of the same activity. So I imagine that key developments are likely to take place at institutions like UVA, institutions that are committed to transparency and are really taking proactive steps, measured and thoughtful way, can we turn this commitment into practice. What are we saying leading organizations doing on disclosure? Well, early and deep involvement of the medical staff is key. Some places, I think, have incorrectly assumed that physicians are an obstacle to disclosure, but if they're not integral to the process, there's going to be a big problem. Some of them are tackling challenging disclosure issues, accepting of responsibility. So the Harvard white paper on disclosures called When Things Go Wrong was very thoughtful and really emphasizes the importance of accepting responsibility. What does that mean? What do you say? Who's accepting responsibility for what? There are lots of unanswered questions in the area of accepting responsibility. Excuse me. Some organizations are pushing forward with disclosure of events that the patients were unaware of. That's really where the rubber hits the road, isn't it? If you cannot disclose and get away with it, what are we going to do as an institution when those cases come up? They're training disclosure coaches, much as Peggy has been working on here, trying to get a cadre of knowledgeable people who can assist clinicians with the disclosure process, and thinking about disclosure as a team sport. Think back to that clip and imagine what could we do to help that healthcare team collaborate and meet the patient's needs a little bit more better. And then lastly, we're involved in several projects where we're measuring disclosure outcomes. So we're collaborating with COPIC, and after disclosure, we actually have developed an instrument that patients complete and physicians complete, rating the quality of disclosure. Those of you who are involved in QI know that the first principle of any improvement process, you have to be able to measure what's currently happening. How is disclosure currently happening at UVA? I would suggest we have very little actual understanding of what this process is currently like. This would be one step that you could consider to trying to understand, so how are patients experiencing this disclosure process? I'll tell you from the COPIC data, patients and physicians don't agree about when effective disclosure has happened, and that provides a real learning opportunity at organizations. So in the future, I think there's going to be ongoing experimentation with disclosure at healthcare organizations, and I think it's going to yield very interesting, useful information about disclosure strategies. But the more people work in this field, the more apparent it is how difficult effective disclosure can be. Some people think, well, how hard can this be? Just go tell the patient what happened. Just go tell the patient the truth. This is what the healthcare workers on the video clips were trying to do, but they lack the skills to do this effectively. And so the institutional commitment and investment in this area, I think, really is important. And we may see additional standards in this area, but I think they're likely to be voluntary until the evidence base around disclosure becomes a little bit more firmly established. So I think we're seeing exciting developments both nationally and locally here at UVA in this area, but I think there's lots of important room to move in terms of figuring out how we turn this principle into practice. Thank you.
Thank you, Tom. I just have a few minutes because I do want to leave time for questions, but what I do want to talk about is the very important role of what nurses think about disclosure. In part because that's my interest as a bedside nurse, and it's the research I focused on with Tom, and in part because, after all, nurses in the hospital are the plurality of medical staff, and so they're going to be involved in these. They're going to be caring for the patients that experience medical error. They may be the one at the bedside more often than the physician, seeking to interpret what has happened for the patient. Just briefly, Tom already touched on this quite well, but some more about nurses' attitudes about disclosure. These are from a series of 4 focus groups at 4 institutions we did in the greater Seattle area, involving mostly nurses that work in hospitals, but within a variety of settings in the hospitals. When it comes to errors that nurses identify as primarily a minor nursing error, for the most part, they were willing to disclose those, often independently as a casual conversation. When there was a bigger error that involved the team as a whole or the physician or had major adverse effects, they did also want to be involved in the disclosure then, but not necessarily to take the lead. Part of that is not necessarily because we just want to be involved in all these difficult conversations and we really enjoy them. A reason that many of the nurses gave for wanting to be involved was they feared that if they weren't part of the disclosure conversation, they would end up being blamed for the error. I think you can see how potentially that insulin overdose error that Tom discussed could easily have been transferred to the nurse instead of the system breakdown that occurred leading to that error being discussed. So the nurses do want to be involved, and frequently they talk about being in a difficult situation around the time errors occurred. And the term that best described this from one of the nurses was walking on eggshells. They know an error has occurred, the nurse does, they suspect it has. The patient's been transferred to the ICU as a result of this error. The family or the patient may suspect that something's wrong. Certainly they know that things are not going as they were expected. The physician may be in surgery for the day. The nurse is continually at the bedside fielding these questions. It's a very difficult time where they feel like, I need to be involved in planning for this disclosure, knowing what's going on, so I can talk with the family without having to skirt around this issue, or at least tell them that there's a plan for talking about what's going on. Nurses are so firmly, I think, situated in the organizational culture, and not so much at UVA, but particularly in private hospitals where physicians are more contractors within the system. It's really nurses that bring to bear what is the organizational culture around transparency and how does that affect how we disclose errors. So that's why these focus groups are so important. Nurses do not see it as just an individual patient-physician conversation, as we talked about. They are aware of the power relationship, though. They will say, I don't feel comfortable bringing this up with the family. Often they do, when an error occurs with major adverse consequences, want the physician to take the lead. And then just to talk, nurses had a lot of ideas about how the overall organizational environment affects disclosure. Without a culture of transparency, just instituting the best designed, best resource disclosure program will not go successfully. So what are the other aspects that were important as we thought about disclosure programs and policies? One was that there was a culture of reporting errors for the purpose of quality improvement. When nurses felt like that was an important thing, that it was productive to report errors, that there were not negative repercussions, that changes were made based on their reporting efforts, they were more likely to also say, I think a disclosure program could be beneficial, and I'd like to be a part of that. Also, when errors were less addressed as individual fault and failure and more as something that unfortunately does occur in the context of medical care and often as a result of systems. So it's not just one individual, but as with the insulin error, there are often several steps along the way. So in institutions where errors were addressed as systems and as opportunities for improvement, nurses were more likely to feel comfortable with the idea of disclosure to patients. And finally, the role of leadership was critical. Without opinion leaders in the institution espousing the importance of disclosure, and without a feeling created that one could talk about errors in that institution as professionals, disclosure really seemed like it might not go well. And third, that although disclosure offers us an opportunity to work together better as teams, and when I say team, I include the patient, the family, physicians, all other healthcare workers involved, non-clinical leadership, risk management. If those pieces aren't already working together to work well as teams, throwing them into disclosure is not necessarily the best opportunity to suddenly form cohesive teams. So working on disclosure without working on how we all work together in interprofessional relationships can be very difficult. Tom had talked a little bit about institutional policies being something that the NQF is encouraging us to have in place. And nurses, policy is a dirty word in nursing because we have books of them and often think, how does this affect our practice? So nurses' reaction to a disclosure policy was somewhat negative until they got to talk about, well, you can do a policy, but we also need to address within that cultural changes in addition to structural changes about how we do disclosure. They were very keen on the idea that any policy about disclosure should allow other healthcare professionals other than the physician to bring up the idea that a disclosure needed to occur in a specific incident. So much like an ethics consult where I could initiate one, anybody doing the medical care could initiate one. They wanted to know that if they were in a situation, a policy at their institution would allow them to contact people who could help set up a disclosure, help them talk with the physician. And just because it's so important, errors are the nightmare for nurses, as they probably are for most healthcare workers. As it's been said, we went into this to help people, not hurt them. So in the aftermath of an error, quickly supporting and then ongoing support was very important. We're fortunate here, I do want to mention it, to have a very active employee assistance program and physician wellness program that are set up to help support physicians and staff during such an error. And finally, that as we work on disclosure policies at our institution, to look at what already works well and to look at who already is helping physicians, nurses, patients, and families with disclosure. And I think my last slide will talk about what UVA is doing. For nurses, nurse managers were their resource. It wasn't upper leadership. It was their daily contact on the unit that set the tone for how this would go. So the people that are already helping should be involved in the disclosure coaching role. I just want to talk briefly about some exciting stuff that's going on at UVA Health System. We are working on an adverse event management plan. And as I said before, this is already incorporating some of the excellent resources we have: employee assistance, physician wellness, chaplaincy, the role of risk management and quality improvement. But it'll formalize the flow of what happens when a significant adverse event that causes harm to a patient occurs. What are the resources? What do we do immediately when such an event is identified? How do we do support after? How do we utilize the role of coaches in preparing for the disclosure? And how do we continue to support the patient and family after that one event of disclosure throughout the whole process of living with an error that has caused harm? We briefly have some time for questions.
Now it's your turn. Some questions and comments? Putting your hand up?
Yeah, sure.
Would you please identify yourself?
Okay, I'm Tim Frazier, med student right here. What do you do with the lag time? Like if there's a mistake that you've made, but it may not show up for 2 or 3 weeks, the patient's gone, and then there's a lag time there. I mean, it may or may not show up in that lag time. I mean, is there a different discussion that happens there?
Disclosure is a process, not an event, and it involves several conversations. The initial conversation needs to happen as quickly as you can get prepared and get support to have that conversation. Often, usually within the first 24 hours after the event's discovered. For events that are discovered after the patient leaves the hospital, that oftentimes involves a follow-up phone call with them, letting them know something's been discovered and we need to have a conversation about it. I think one area of considerable dissatisfaction from patients' perspective is the delay that happens either between the event and the initial disclosure, or even more commonly between the initial disclosure and the follow-up conversation because the analysis has taken so long to conduct. Places like Stanford have committed to basically having a complete analysis done of major events within 7 days and being ready to get back to the patients within that time frame. So figuring out how to do this and making it a top priority to provide timely information to the patient, I think is important.
I'm Ann Hamrick. I teach in the School of Nursing. And thank you both for this. This is very important, and it's a source of huge worry to nurses in many places. I'm very familiar with your study that you did with Sarah Shannon, and I guess one of the questions is whose responsibility is it to get this ball rolling? The idea that it should be the team, nurses do tend to hold back and say, well, physicians need to start this, or managers or somebody. How do you get this momentum going on a particular unit when an error has occurred and it's clear that we need to get more than just a physician involved? What strategies do you have for frontline caregivers in getting the ball rolling?
What are your thoughts, Mary?
As I said, nurses identify their nurse managers certainly as somebody who helps them get the ball rolling and can be an advocate in this. And I think, as you said, Dr. Hamrick, it's important to, as we create a structure, look at the different ways that different professionals would feel comfortable accessing the system. For a physician, they may feel comfortable making that initial call to liability or risk management. Nurses may end up in the office talking to their nurse manager, and both need to be point of entree to sort of activating the support and bringing people to talk about and plan for a disclosure.
And it's an important role that disclosure coaches often play, is helping the healthcare team move forward rather than relying on the initiative of any individual provider. I will say sort of our experience, in addition to the focus group, has been that some senior and experienced nurses feel comfortable with disclosure, but the majority of the less experienced, more junior nurses find this area terrifying, and so they really could use some support. And they worry way more about losing their job or losing their license than physicians do. It's not even on physicians' radar screens. They worry about getting sued, but we've heard over and over again, hopefully the climate is more positive in Virginia, but apparently in many states, the nursing board is much more punitive than I had imagined. But thank you for that comment. There are some very interesting attempts to engage patients in error prevention. They vary in their success. So, for example, patients are perfectly happy to ask doctors about medicines. They're less interested in asking the doctor if they've washed their hands, another common recommendation. And I think the challenge is, how do you balance engaging patients in error prevention without scaring them? The hospital is a place where they ought to be able to trust that they're getting high-quality care and don't need to be sort of constantly vigilant, but errors do happen. And how do we engage patients while maintaining their trust and comfort, I think, is a real challenge.
Thank you. I'm afraid that we're out of time, but you have engaged us, both of you have engaged us very seriously and engagingly today. And we welcome your comments and some further questions for a few minutes down here when we're finished. We invite you to join us next week on the 11th of March for a program on the book that's now, I think, 46 years old, Our Bodies, Ourselves, often referred to as women's owners' manuals for their bodies. We have Sue Wells here from Temple University, and then Joanne Pinkerton and Miriam Bender from Charlottesville for that program. Please join me again in thanking Tom Gallagher and Mary Hardy.